This lecture is on chemotherapy, and we're going to be focusing on the drugs. The second lecture is going to be focused on some treatment options, and that one's going to be shorter and not tested on. So this is the more important lecture as far as exam purposes go. Cancer is a group of diseases that accounts for 25 to 25% of all deaths in clinical practice. So it's quite significant, and it's something that it's difficult. We still have a lot of cancers out there that are quite difficult to treat. We can treat cancer with three ways: operation, radiation, and with drugs or chemotherapy. And of course, I'm going to focus on the drugs. And you can, of course, use all three at the same time, too. You might target certain local areas. You might use drugs to target a more systemic response. Drugs are always going to be, well, it depends on how you want to view it, but drugs are going to be more prone to side effects due to the fact that they're affecting other tissue. However, you could think about operations. Significant operations can require a lot of recovery. Radiation doesn't have has its own issues with it as well. So nothing's perfect, but chemotherapy tends to be pretty tough on the body, specifically with some of the treatments we use. Cancer, just an infographic showing some of the statistics behind which cancers are most common and what types of prevalence we're looking at. This is a more interesting one, I think. It shows the different types of cancer as far as new cases per year and the death rate as well. So you can see in the dark bar, that's how many people are dying from cancer, specific ones. So you see lung cancer, quite a few new cases, pretty high death rate compared to some other places. Look at like breast or prostate, you can see much, much lower rates of death per new cases, but also much more common. So just because the cancer is common doesn't mean it's going to be a significant killer of people, but it is, lung cancer is kind of the balance, I guess, if you want to look at it that way. It's got both high amount of new cases a year and a high death rate. If you look at something like pancreatic cancer, pretty much the death rate's almost right at the new case rate. Pancreatic cancer is very difficult to treat, and again, the death rate's quite high. And we see some of these less common ones also, with maybe the exception of bladder cancer, kidney cancers, leukemias and lymphomas. There's all types of different variations of those. So really it could depend on what type. Some leukemias might have a much better prognosis than others. It's just kind of interesting to think about this as we go through and talk about the treatments for these options. This is just some data on US rates of cancer. I'm not going to go through it, but it's there for your information in case you're curious. So when we talk about treating cancers and overgrowth of cells in various areas, so usually what you're looking at is solid tumors, which is what you would think of as you have some sort of a tumor in some area of the body that's growing, some sort of a mass. And then you have what you could refer to as like a liquid tumor, but it's easier to think about it as the hematologic cancer. So these are the leukemias and possibly lymphomas, which can be related. And these are going to be more affecting your white blood cells and other neutrophils and those types of cells, as opposed to causing solid masses in places. So when we look at cancer cells, we're looking at two different types: proliferating and non-proliferating. And the ratio of these is called growth fraction. And why this is important is because a tumor that has a high growth fraction will be more sensitive to drugs. Drugs are designed to target cells in a proliferating state. So if you have more cells in proliferating state, the drugs are generally going to be more effective. Sometimes with really slow growing tumors, it's difficult to treat them. If you can't, I mean, you could resect them with surgery potentially, but from a drug perspective, it can be hard to treat because they aren't proliferating fast enough to adequately kill them with the current therapies we have. Now, there's some ways we can get around it. We'll talk about some therapies that work for that potentially and are maybe a little bit more broad spectrum, but generally that's difficult. So the high, fast turnover tumors are easier to treat for the most part. So we have four different cell phases, and there's GAP1 or G1 phase, which is a pre-synthetic phase, so the cell is prepping for synthesis of DNA. The S phase is the synthesis itself of DNA. Post-synthetic phase is when you start to duplicate and will divide the DNA to support two future cells. Excuse me. And mitosis is when the cells actually finish completion. So that's our cell cycle process. And when we talk about the drugs, we're going to talk about different phases they affect. So G1, G2, S phase. Some drugs affect all phases, and some drugs will affect phases in G0. So G0 is considering the non-proliferating phase. So when we talked about ratio of proliferating to non-proliferating, G0 is the resting phase. All these cells can move into a proliferation phase, but something has to trigger that to happen. And what we can do in the way we treat cancer, if you've ever worked with cancer patients, you'll know that they do chemotherapy in cycles. So normally you come in for chemotherapy on day 1 and you get your intro regimen. And then you maybe come back in a week or 2 for another regimen. Could be a month. It really depends on the type of cancer, and the cycles can vary in their frequency in between. But you're looking at some time in between. The idea is that when you give somebody their initial dose of chemotherapy, you're going to do a pretty good job wiping out all your proliferating cells, but at the same time, you're leaving potentially non-proliferating cells as well that have the potential to become cancerous. So you come back in with another phase of chemotherapy, and the cyclical nature of this hopefully eradicates the cancer eventually. So antineoplastic drugs, also known as chemotherapy, what they're doing is mostly acting on proliferating cells. Now, again, there is some potential, and some of the drugs we talk about do work on the non-proliferating cells too, but they work through a variety of mechanisms. Most involve DNA synthesis and destruction directly of DNA. And some may work downstream to inhibit protein synthesis. And we have a group of drugs that interfere with hormone balancing. This is more associated with prostate and breast cancer, and we aren't really going to talk about those. I'm going to do some more specific, because they're such common diseases, I'm going to be doing some more specific lecturing on that during Men's and Women's Health next spring, but we aren't going to get into those details today. Toxicity, you're looking at mostly experiencing short-term toxicity with chemotherapy, and not that it's pleasant at all, but the long-term side effects are usually not something we consider because most people aren't on chemotherapy long-term. Think about blood pressure management. Somebody might be on a blood pressure regimen for 20 years. Somebody's not going to be on the same chemotherapy regimen for 20 years, hopefully. Usually it's going to work or it's not, and they're going to move on to another treatment plan. So when you're looking at short term, you're looking at areas in the body that are going to be affected by chemotherapy are areas with high proliferation. So hair, bone marrow, and GI tract. So a lot of these drugs we're talking about are going to cause hair loss, they're going to cause nausea and vomiting, they're going to cause myelosuppression, or suppression of the bone marrow's abilities to synthesize new cells. And that is shown through our, well, if you think about what we just talked about with the first lecture about anemias and the colony stimulating agents, those can be useful to help the bone marrow overcome some of these side effects from the chemotherapy, suppressing their ability to do so. And again, long-term side effects, not too worried about it. There may be some fertility issues. For women who have or women of childbearing age, teratogenicity could be an issue to think about too. For the most part, we aren't too concerned with long-term side effects. There's a couple of classes we're going to talk about today, and I'll go through them each. For the purposes of testing with this material, it's important to know the classes. I'm going to point out a couple drugs. There's a few drugs that are on slides that'll tell you don't need to know. Most of the ones that you need to know are bolded. And I would like you to know which class they generally fall in. So are they an alkylating agent? Are they an antimetabolite, natural product? And then we'll talk about which phases of the cell cycle they work into. Alkylating agents form a reactive alkyl group that forms a bond with nucleic acid, and so it cross-links DNA strands, causing ultimately them to break. They aren't really specific to any phase because they can work on any type of DNA. So not only are they widely used in different oncology indications because of their broad spectrum use, they are unfortunately not very selective, meaning that they cause other issues within the body, so side effects, of course. Myelosuppression is pretty common, so you tend to find patients on these to be fairly neutropenic. And also acutely, they might be a little bit more emetic than other regimens, so they're going to cause some more nausea and vomiting than we might see with some of our other drugs. Cyclophosphamide is one I would like you to remember. Cytoxan's the brand name. It's a widely used chemotherapy. It's actually a hepatically available prodrug with good oral bioavailability, so it has to be metabolized into its active form. So that could potentially put it at risk for being affected by drugs that inhibit different types of enzymes. There's a couple other drugs on here that I'm not concerned you know. I put a page number on here. The book has some tables with all the drugs in them. And that page number might be out of date. I can't remember what it is on the newest one, if that's correct or not. But sorry if that was choppy. My recorder just cut out on me. But the point I was making was that with the book, you just want to, if you want more information, there's plenty of different chemotherapies in there. We don't have time to go through them all. So really for this slide, I want you to focus on cyclophosphamide. Another group of alkylating agents, even though they technically are kind of in their own class of platinum analogs, they work the same way, are the platin items. So there's cis, carbo, and oxaloplatin, and they're different generations. These drugs, especially cisplatin, is quite renally toxic and can cause sensory neuropathy and ototoxicity. With the higher generations like carboplatin, oxaloplatin, you have less renal toxicity. You don't have the same ototoxicity. They still can cause peripheral neuropathy, but overall much better tolerated. These are popular agents. Again, alkylating agents are very broad spectrum, so they're useful in almost all types of chemotherapy. Antimetabolites act by replacing your natural metabolites into DNA replication, so you're going to subvert your entire cellular replication process, therefore preventing DNA from replicating. We have a couple different examples here. I'm going to go through some of them. Cytarabine and 5-fluorouracil are two common ones. Cytarabine is a really specific for S phase. Think about the phases of the cell. The DNA synthesis phase, or S phase, makes the most sense for an antimetabolite to work right. If you understand the concept of what an antimetabolite is, replacing a DNA base pair, you should be able to remember it works in the S phase. It does cause some, cytarabine does cause some neurotoxicity, and it can cause this hand-foot syndrome that causes sloughing of the skin. 5-fluorouracil is another similar agent. A couple others, 6-mercaptopurine inhibits purine biosynthesis, and methotrexate mimics folic acid, which is needed to synthesize nucleic and amino acids. However, it's enough of a different molecule that the body will think it's folic acid, use it, therefore it can't synthesize the correct base pair appropriately. Therefore, you get, again, a disruption in S phase. Methotrexate is a really commonly used agent that's kind of a general immunosuppressant. It's really useful in a couple different autoimmune diseases we're going to talk about next spring, I think. But for now, it is a really important part of a lot of different chemotherapy regimens, and it's commonly used. Natural products, there's a couple different classes of them, and they all sort of are derived from different natural sources. There's some antibiotic agents. So these are actually produced by Streptomyces species, and the mycins cause double-stranded DNA breakage, mostly active in G1 for dactino and mitomycin, and cause accumulation of cells in the G2 phase because they can't get beyond that. Anthracyclines like doxorubicin, daunorubicin, the rubicin drugs, are pretty widely used medications as well. They promote oxygen-free radicals to bind to DNA and cause breakage. So again, we're targeting DNA and disruption of DNA synthesis. So they're going to be pretty broad spectrum because they can really bind to DNA in any state. They don't have to be specific to a phase, and this is anthracyclines we're talking about here. But for the most part, widely used chemotherapy because of that. Vinca alkaloids, or they start with vincristine and vinblastine, are derived from the periwinkle plant. What they do is they bind to tubulin, so they're kind of a different mechanism. What they're going to do is interfere with assembly of spindle proteins during mitosis. So this is the first drug we have that really just acts on the M phase alone, and you block that final step of cell proliferation. So if you're starting to think about these drugs in your head of having different activity in the phases, it might start to make sense why with chemotherapy we rarely ever use one agent. We're combining things to make sure we're covering multiple different mechanisms. So the best thing we want to think about with chemotherapy is mix your mechanisms up. It's kind of like infectious disease from a standpoint. We haven't quite gotten there yet, but we're going to talk on Monday about some of the different treatment strategies, and a lot of times we're mixing mechanisms of action to try and best kill the bacteria. It's the same thing with chemotherapy. If you have something that works in the M phase, it might be nicely synergistic with something that works primarily in the S phase, because you're going to get cells that are already in the M phase and also cells that are entering the S phase. Vinca alkaloids cause some myelosuppression, neurotoxicity, SIADH is syndrome of inappropriate antidiuretic hormone, which can cause some electrolyte disturbances. It's a kidney issue. We'll talk about that more with renal. Vincristine is generally the better tolerated drug and probably the more commonly used drug out of these ones. Taxanes, you have the Western yew tree, which is is the derivative of this product, and they end in taxol, so paclitaxel and docetaxel. They inhibit microtubule assembly similar to our vinca alkaloids. I think the slide set I had says something else, but vinca alkaloid is the correct one. I updated it for this recording. Good activity against a pretty broad range of cancers. Again, fairly commonly used medications here, and also they're working in they're working in the M phase, so a different mechanism than some of the other drugs we've talked about. Topoisomerase are a couple different enzymes that regulate different types of DNA overwinding and underwinding. So when you have production of DNA and synthesis and duplication of DNA, these are going to interfere with some of the enzymes that help those processes move along. So we're looking at S phase, G2 phase primarily. Topoisomerase 1 and 2, to be honest, I don't know what the huge difference is. They probably have some subtle differences, but they're probably looking at mostly working in the same phases. You're looking at some with the etoposide products. I'd like you to remember etoposide specifically. Don't worry about it, so I'll bold this one for you. It won't let me for some reason. Sorry. Etoposide. Oh, there we go. Now I can bold it. Etoposide, teniposide, don't worry about that one. Etoposide is a really common chemo. And then irinotecan and topotecan, just remember one of these. We'll say irinotecan. It's probably the more commonly used one. And both of them have some significant side effects. The etoposide is going to be more about hair loss and myelosuppression. And then you're looking at more GI effects with irinotecan. Hormones and antagonists, I'm not going to talk about these a lot. Actually, I'm going to kind of blow through this slide right now. Suffice to say that hormone therapy has a big role in certain types of cancer and a very minimal role in other types. And that's all I want you to know for this. I'm not going to ask you any questions about hormone therapy. We're going to cover that more in detail next spring. Okay, getting into some of the more interesting stuff. Now, while that's kind of interesting, it's old school chemotherapy in the sense that we're targeting the destruction of various types of the cell cycle. Biggest problem being we also hurt our patients in doing that. And while, yes, the outcome is much greater that we can possibly cure cancer by doing that, and therefore a little nausea and vomiting, even if it's severe for a short period of time, is tolerable. These drugs we're going to talk about now are getting away from that broad spectrum approach and looking at more of a focused approach. And so I probably should dedicate much more time to biologics, but it simply changes so often that it's very difficult to keep up on it. And this is really the forefront of cancer treatment right now. This is what we're going to see all the new chemotherapies being. We're going to see a lot of these old treatments potentially still be relevant, but these new drugs, either repurposed drugs or new biologics coming out, are really the future of cancer, in my opinion, of cancer treatment. So let's talk about a couple different things. So we've got a big category of drugs are epidermal or vascular endothelial growth factor inhibitors. So when your body wants to build new blood vessels to supply new tissue with blood, they use growth factor specifically to build vascular vessels. And what they've done is develop drugs that can inhibit that process. And they do pretty well to inhibit very specific ones that are associated with cancer growth. For example, the microvascular growth of a tumor is really important to supply it with blood so it can keep growing. So if you cut off the blood supply to that or prevent it from growing new blood, it can't expand further. Ultimately, you can kill the tumor altogether by doing that. One drug we've been using a lot at my hospital for brain tumors particularly is called bevacizumab or Avastin. Avastin is kind of an interesting drug. You may have actually heard of it. It got some press a while ago because it's a common treatment for some types of ocular disorders, which we'll talk about during eye a little bit. But it's a really expensive drug, but it has a decent use, and it's been shown for solid tumors, specifically in the brain, to be actually quite effective. Brain cancer is historically a lot reliant on surgery. However, this is a drug that's changed that a little bit in how we view treatment of brain cancer. So again, we're by giving these drugs, we're cutting off the tumor's ability to build new blood supply, which is very useful in preventing tumors from growing and killing tumors altogether. There's a couple other monoclonal antibodies. I just put an example of one called rituximab. We're going to talk about a couple of these during our transplant medicine lecture, which is going to come up pretty soon here in the next month or so, when we talk about the immune system and how we can suppress that. But for example, rituximab is a drug that targets specific antibodies on various cells associated with immune response, like T cells. And so if we can target those specific antibodies to prevent the activation of the body's own immune system, we can therefore use that same drug to target an overexpression of it. So for certain leukemias where there's too many white cells being produced, maybe this is a drug that can be useful. So this is an example of a repurposed biologic that was useful for suppressing the immune system that they found is also useful for keeping certain types of hematologic cancers in check. And then we have the whole concept of immunotherapy. This is really the future. This is what everyone talks about, and I only have one bullet point on it. Immunotherapy is basically the ability to modify the body's own immune system to work against the cancer. It's very interesting, and this is where a ton of research is going on right now. We don't have a lot of options for immunotherapy right now on the market, so that's why I didn't really talk about it a lot. However, in 5-10 years, hopefully we're going to see this. The reason being is because it's really kind of a perfect case scenario. If you can get the body's own immune system to do the work for you, you're going to be working and augmenting the body's natural defenses, which is going to be much more effective and much better tolerated than really anything else we've been doing with cancer, in my opinion. So immunotherapy is really cool. One example of a way that they've been doing immunotherapy is kind of think about the concept of a vaccine. You've probably learned about vaccines in different classes in undergrad. Hopefully you've been exposed to it at some degree. We'll talk about it a little more detail next when we talk about pediatrics, actually. But the concept behind a vaccine is what? You're just giving something that's antigenic, that's going to cause the body to have some sort of immune response. It's not enough to cause any problems, but it builds enough of an immune response so the body can recognize a threat when it comes in, therefore neutralizing it. And the immunotherapy works really the same way. One clinical trial, and this drug is actually approved now, it's called Telimagene hepaviric or something. I can't remember the exact name, but it's a modification of the herpes virus that they've used, and they basically have been injecting it locally into skin cancer lesions, and it causes a local response because the body thinks that there's some sort of new virus there, so then it sends immune system to fight it, and the virus is designed and specifically engineered to mimic the cancer. So not only does it try and fight the virus, but it also tries to destroy the tumor in the process. So it's very interesting, very smart way of thinking about approaching therapy and a different way of thinking. And I think it's cool. I think it's, again, something that we're going to see a lot more of in the future, hopefully, because I think it shows a lot of promise, at least on a surface level. Tyrosine kinase inhibitors is another thing I wanted to dedicate a slide to. Tyrosine kinase inhibitors are big drugs right now. They're very expensive. They have a lot of niche indications, but basically they got their start in chemotherapy, but we're seeing them used for some different diseases, specifically some autoimmune diseases too. Tyrosine kinases are a group of enzymes that activate a variety of cellular proteins. So basically, if you inhibit different types of tyrosine kinases, you're going to decrease the cell's ability to produce essential proteins, therefore causing eventual cell death. And so, of course, based on that mechanism, it should be clear why that's useful in chemotherapy. We want to kill overgrowth of cells. Well, this seems like a good way to do it. They're really popular drugs. They're super expensive. I'm actually going to post an article that's a couple years old, but I think it's still interesting, just about some of the financials surrounding specifically the drug Gleevec. Imatinib or Gleevec is the drug I use as an example, but again, there's several of these. They all kind of end in NIB. And these drugs are all oral, so that's really interesting. When we talk about other new therapies, specifically biologics, you're looking at intravenous or sub-Q, highly expensive, large molecule injectable only products. We're looking at tyrosine kinase inhibitors. They're actually small molecule drugs that are PO. So that's nice because it's easier to give a patient a course of a PO drug than have them come in every so often for an infusion. So Gleevec was a drug, or imatinib was developed for specific chronic myeloid leukemia patients. And so what the drug does specifically is this specific tyrosine kinase inhibitor prevents proliferation and induces apoptosis in a specific type of tyrosine kinase that is only associated with people who are Philadelphia chromosome positive with this specific leukemia. So it's got this very niche indication, but what they found with tyrosine kinase inhibitors is they can really specify them to be they can really design them to be very specific for certain areas. So Gleevec has a lot of other indications, so it doesn't only work with this specific one, but this is what it was developed for. Now we're seeing it useful in a wide variety of cancers that aren't necessarily even related to leukemia. So I mentioned combination therapy. Combination therapy is almost always indicated, with the exception of some of these newer therapies. We might, in the future see us going towards, maybe we're only using biologics in 20 years. Maybe we're only using immunotherapy in 20 years. That's a possibility. But right now, combination therapy is key. We want to use combination therapy for a number of reasons. You're going to enhance the curative effects. If you're combining mechanisms of action, you're improving your ability to kill the cancer, therefore the ability to help your patient. Decreased toxicity. You can get by with less of each agent. So if you're giving one agent and you're trying to use that as your sole chemotherapy agent, you may need to give a massive dose to actually get a response. Whereas if you combine it with two other agents, you might get enough really good synergy. You can lower your doses all across the board. And yes, you're giving more drugs, so there might be more possibility for a variety of side effects, but the idea is you're suppressing the ability of those side effects to rear their heads because you're limiting the overall exposure of chemotherapy. And drug resistance, just like antibiotics can develop resistance, different types of cancer can develop resistance and resistance mechanisms. I'm not going to go into detail on what those are specifically. If you're interested, I'm sure you can find articles online that explain it pretty well. But the point is that when we have resistance to one drug that's a commonly used one, that hurts us. So if we can mix our mechanisms up, we can decrease the ability of a drug to become resistant to just one type of chemotherapy. So I think I mentioned those advantages there. Again, there's combination therapy is almost used widely across the board. So our goal here is to urge as many G0 phase interproliferation as possible, like I talked about at the beginning of the lecture, just to review. So our high growth factor in tumors, the general process we're going to do is to first kill our S and M phase cells, and then we're going to use non-specific agents to try and kill anything else. And we want to repeat that to kill any G0 cells that are turning over. For low GF tumors, remember things that are solid tumors, possibly. Leukemias tend to be a bit higher of a growth fraction turnover. When we talk about low GF tumors, you're talking about maybe more solid tumors. And so we're going to try and use our non-specific agents first to wipe out anything that's going on. Then we switch to phase S and M, and then we repeat. So basically, it's the same real process, but if you're looking at a regimen, you're always going to start with your S and M phases in high growth, and then you're going to use those secondary in your low growth, and it's just a flip-flop. And of course, surgery and radiation, depending on if it's indicated, is always appropriate and can be combined with our drugs at any time. Here's a regimen example. This is called CHOP, which is a kind of a historically famous regimen. It's cyclophosphamide doxorubicin, which there's a more scientific name, which is called hydroxydonorubicin, but we call it doxorubicin as a generic name. But the H, that's where that comes from. Vincristine is brand name Oncovin, which is where the O comes from. And P is prednisone. Prednisone is a corticosteroid that's a broad spectrum immune suppressant. We'll talk about steroids in a couple lectures here. But that's a lot of these regimens have acronyms like this, and they're kind of weird as far as how they decide where the letters come from, but they like to make them sound, catchy. CHOP is pretty catchy, I guess, as opposed to saying like CDVP. No one would remember that. People can remember CHOP. So what is CHOP? CHOP is cyclophosphamide, which is an alkylating agent, plus you have your doxo, which is a direct DNA damaging agent. So you have two, and alkylating agents are directly DNA damaging too, but you have two different mechanisms going on to damage DNA. You have M phase inhibition via vincristine, and you have immune suppression via prednisone. This is a therapy that's used in non-Hodgkin lymphoma. It's usually given every 21 days for a determined number of cycles, and you monitor your CBC for 10 to 14 days after treatment, plus or minus rituximab. Sometimes CHOP adds on rituximab as well. Remember, rituximab can work with certain types of leukemia and lymphomas to decrease the body's overexpression of those tumor cells that are causing increases in blood dyscrasias. So while I'm not going to ask you about what CHOP's used for, what I might give you on an exam is CHOP, and I might ask you, okay, what's the cyclophosphamide for? What phase does the vincristine work on? What phase does doxorubicin work on? In fact, that's probably a good thing to remember is CHOP. And if you want to use this as a springboard, I wouldn't neglect the other chemotherapies because they are fair game, but I would know this slide pretty well, and you should be okay as far as knowing which drugs work where. Some other tips to think about: combine drugs with different toxicities. You want to have low tox plus high tox. So if you have something that is a really highly emetic drug in a regimen, meaning it's going to cause a lot of nausea and vomiting, you want to make sure that the other drugs in your regimen aren't equally as highly emetic, just because you don't want to overwhelm the person. You want to select drugs appropriately. So different drugs have different spectrums of activity. Again, when we talked about our mixing our mechanisms of action, makes sense. Dose appropriately too. Dosing with chemotherapy is often done a little bit differently than anything else. We dose it in milligrams per meter squared, which is different than weight-based dosing, and it's different than just standard dosing. So it's kind of an interesting thing, especially for anything IV and a lot of the basic drugs. Biologic agents, it's a little different, and tyrosine kinase inhibitors are different. They aren't dosed that way. But for the most part, we're dosing our standard chemotherapies in milligram per meter squared. Sometimes weight-based and sometimes just a standard dose, but it's more unusual. Okay, I just want to touch base on a couple chemotherapy complications very quickly because I think it's important to address it a little bit. I will ask a couple very general questions on the exam, specifically with nausea and vomiting. Now, I know we haven't covered these drugs. We aren't going to be covering them until our GI lecture, but because we have a lot of highly emetic chemotherapy regimens, I think it's worth mentioning. I skipped to this slide really quick. I'll just show you I have this slide included. This is the emetic potential of antineoplastic agents. So you can see basically how drugs fit into different categories. So minimal risk, really high risk. So again, you don't want something with really high risk, multiple versions of it, multiple ones from this category together. You'd mix something high, maybe something moderate, and then something low or minimal. That'd be ideal. All right, so we have a lot of antiemetic agents. You have a couple different ways you can do this. So basically, you're going to suppress the chemo trigger zone within the body, and you have a couple different options to do this. And again, we're going to cover all this in the spring, so don't worry too much about this. As far as remembering how we treat nausea and vomiting, I'd remember the classes. So know that we have 5-HT3 is a serotonin, it's an abbreviation. 5-HT receptor antagonist, so we do serotonin antagonism within the central nervous system. We can antagonize dopamine receptors within the chemotrigger zone, which can help. Benzodiazepines are often used for anxiety, but they also work pretty well for nausea and vomiting too. So lorazepam is a common drug for that. And we have another drug called aprepitant, which is a specific only to chemotherapy. It's substance P, which is involved with the body's ability to sense pain, and for some reason it actually has an effect on nausea too, and that's a drug that is given too. So when you're looking at developing a regimen of chemotherapy, you always look at the emetic potential of it, and a lot of this is protocol driven. So if you're at an institution that does a lot of chemotherapy, they're going to say, okay, we're going to use CHOP. CHOP has this much emetic potential, which means by protocol we give this, this, and this. And so from a standpoint of how do you decide what to give people, usually, again, there's a lot of published literature out there, and there's pretty well-respected guidelines as far as, okay, if they're high risk, you would give these agents. If it's moderate risk, you'd give these. And I'm not going to expect you to know that. I'm not going to go into detail on that beyond what I just said, but I just wanted to point it out because it is a big part of treating chemotherapy. Remember, almost all the drugs we talked about cause nausea and vomiting, so you have to have some sort of a solution in mind for that. Immune suppression. So, when patients get immunosuppressed, you increase risk for infection, of course. And one of the common complications is called febrile neutropenia. It does require hospitalization. So, if somebody's undergoing chemotherapy and they come into the hospital, these patients will present with a fever of unknown origin usually. Sometimes they have an infection that's clear. Maybe they have a clear pneumonia or a clear, I don't know, bloodstream infection potentially. Not that that's really clear. You'd have to get labs for that. But bear with me for a second here. Let's just say, for the most part, patients might come in with a pretty general presentation as far as they look infectious, they have a fever, they're neutropenic because they're being treated with chemotherapy, and you don't have a very good idea for their source. These patients, because they've been exposed to chemotherapy, because they've probably been in the hospital recently, and because they're immunosuppressed, means you treat them broad spectrum. So we give broad spectrum antibiotics. You treat them basically like a sepsis case. And we're going to talk about sepsis on Monday. But you treat them with something broad spectrum. So you're going to cover MRSA. So usually these patients are getting vancomycin, and they're getting something that's one of our big broad spectrum gram-negative guns, like cefepime, piperacillin tazobactam, aka Zosyn, or imipenem or some sort of carbapenem would be another choice. But they're going to start out very broad spectrum. It's very difficult to figure out what exactly is causing it. So usually you're going to treat them broad spectrum, and hopefully they get better. You can try and culture them, but that's not always fruitful. But you can do a blood culture before you would start your antibiotics and try and narrow down your possible source of infection. Sometimes patients will be on prophylactic agents. George is going to talk, I think, about some prophylaxis of HIV on Monday, but it's very similar. So we prophylax against a variety of possibly opportunistic infections. Opportunistic infections are ones that come up when our immune system has crashed. And so there are things that we encounter on a day-to-day basis. A lot of them are fungal. There's some opportunistic bacteria out there. So we can prophylax against those with small doses of antibiotics and periodic intervals to try and prevent that from happening, depending on how immunosuppressed that person is. And if a patient has become significantly immunosuppressed because of their chemotherapy, once their cycle's over, we can use colony-stimulating agents to get them back up to speed. In fact, a lot of times patients will end up sitting in the hospital for a couple days waiting for their counts to come back up because simply they're too fragile to send out into the real world. You don't want them exposed to everything on the street because their immune system's compromised. You just spent a lot of work getting this person's cancer under control, theoretically, so you don't want to send them out and give them some sort of a nasty infection to follow up what they just went through as far as chemotherapy treatment goes. Tumorlysis syndrome is something that comes up when you destroy a whole bunch of cells at once. You end up releasing things into the bloodstream. So if you're kind of doing a little bit of killing of cells, it's not that big of a deal because the body can handle a little bit of fluctuation and whatever is getting leaked out of these cells. However, if you do this in large scale, so if you have a pretty high tumor load and you're using aggressive chemotherapy, this is something that can happen. So what happens is intracellular contents of your cancer cells that you're killing, as the cells are being lysed, you're leaking them out. So you're getting increases in serum potassium, phosphate, and nucleic acids. So the problem with potassium is high potassium can cause significant cardiac effects. That's by far the most problematic. Phosphorus, your kidneys can do a pretty good job clearing that, not as big of an issue. Nucleic acids, as they get leaked out from these dying cells, can accumulate in the kidneys and elevate uric acid levels, and they can cause some, as your body tries to eliminate them, and this can cause kidney injury. So we have some possible issues with tumorlysis syndrome. To prevent this, if somebody is thought to be undergoing a chemotherapy regimen that's going to be causing potentially tumorlysis syndrome, IV hydration is very important to make sure those kidneys are flushing out any extra electrolytes. Again, kidneys are really good at clearing not only potassium and phosphate, but they'll clear out those nucleic acids. You just can't let them accumulate, and we want to help the body eliminate them as much as possible. So hydration's important. Alkalinizing the urine can help to eliminate some of that uric acid. And then we have some agents that are specifically hypouricemic. There's a drug called allopurinol, which is used normally to treat patients with gout to prevent the formation of uric acid crystals in the joints that gout affects, which we're going to talk about next semester. But it can be useful in this situation because prevent that formation from occurring in the kidneys. There's also a drug called rasburicase, which promotes degradation of uric acid too. It's a more expensive agent. It's more used for severe cases. So if you wanted to treat somebody with tumorlysis syndrome, again, you're going to treat them with IV hydration as much as possible. Electrolyte abnormalities you're going to treat as needed. So if somebody's potassium goes through the roof, we can give drugs to treat that. We're going to talk about that at the end of the semester. You could always send somebody to dialysis to dialyze it off if it was really urgent. Otherwise, rasburicase can be given to prevent that uric acid buildup and to save the kidneys. All right, so cancer is not a funny topic, but here's a joke. The good news is it's not cancer. The bad news is those steroids you bought online only work to bulk up your neck. Not a tumor for this guy, fortunately. All right, so that's basic chemotherapy in a nutshell. Again, I don't want to spend a ridiculous amount of time on it because it's so specialized that really, unless you work in it, you're never going to really use it. So with that being said, I'll go through the next lecture and you can listen to it at your leisure. Again, it's not testable material, however this lecture is.